Hi, my name is Ali Yılmaz. I'm a pediatric radiologist at McMaster Children's Hospital, and I'm going to talk about pediatric chest radiographs. This will be a basic introduction lecture for the learners. And here is the outline of my talk. It will be including the technique, interpretation, normal variants, paravertebral opacities, pneumonia, pneumothorax, foreign body ingestion and aspiration, and finally trauma. Let's start with the technique. As in every other field of radiology, there has been marvelous developments in X-rays. Here you can see one of the very early X-ray units. The frame is made of wood. We are currently using more advanced equipment with robotic arms and wireless detectors. Everything is digitalized. I remember the company advertising for this X-ray unit here. Like, we are using the same detectors that NASA is using on their satellites as sonar panels. That's actually correct. The detectors are doing the same job. On the satellites, they convert the sun waves into electricity. On the X-rays, they convert X-ray waves into electricity, then to light, which are then encoded as an image. In pediatric radiology practice, stabilization of the patients is very important, as infants and younger children are usually not cooperative. Pigostat was introduced in 1960s, and similar equipment can be used to stabilize children during the X-ray studies, as you can see here. Let me continue with a question here. If I ask you which X-ray is abnormal, A or B? Most would say A is abnormal. Even the pediatrician who consulted me this case thought there was an enlarged heart, mediastinum, maybe some lymph nodes, and diffuse hazel lung opacities. However, these X-rays are actually of the same patient with just 15 minutes interval. After I saw the first X-ray, I realized that this was an expiratory view, and I asked the technologist to repeat after removing the clots. The repeated radiograph during inspiration looks perfectly normal. I can tell that this is an expiratory view by counting the ribs 1, 2, 3, 4. The fourth rib is intersecting the dome of the right hemidiaphragm. This is usually 5th to 7th in younger children. On the repeat study, it is intersecting the 5th rib, and the hazel opacities are gone, and mediastinum and heart look normal. So the technique is important. To show you the differences during inspiration and expiration, I would like to show you my own chest X-rays during full inspiration and full expiration. I didn't have any symptoms at this time. Here you can see that 6th rib is intersecting the dome of the right hemidiaphragm on the full inspiration, and 4th rib is intersecting the dome of the hemidiaphragm. 1, 2, 3, 4. So during full expiration view, the mediastinum and heart looks larger, and the lungs appear hazy with some interstitial prominence. Do we really need a lateral view of the chest? Well, routine lateral views is not recommended in pediatric population due to an additional dose, because the dose is higher than the frontal projection due to increased body thickness. Also, the interpretation of the lateral X-rays is challenging. Having said this, it is really a good idea to get a lateral view and to get rid of superimposition. This is the main disadvantage of X-ray compared to cross-sectional imaging. Overlap. You can have an overlap, and this can be missing a large tumor hiding behind the heart, as in this case. This case, a 4-year-old presenting with inability to walk for a month, got a delayed diagnosis because the initial frontal projection, frontal projection, was interpreted as normal. But on the lateral view, it can be seen here, and on the cross-sectional images, you can see it very easily. After talking about the technique, I would like to talk about interpretation. On the X-rays, there are 5 main densities that can be distinguished according to their appearance on the X-rays. Metal has the highest density, then calcification and the bones, then soft tissue and fluid, and then fat, as here you can see the subcutaneous fat, finally air. As you can see, we can easily differentiate metal and air, but not possible for the soft tissues and fluid. We should be familiar with the radiologic anatomy. Here you can see the trachea in the midline, the carina, right main bronchus, left main bronchus, the right hilum mostly composed of descending pulmonary artery, the heart contours, right atrium, right ventricle here, we don't really see it, left ventricle, left atrium, and pulmonary conus, and we can see the aortic notch and the descending pulmonary artery contour here, the manubrium sterni, clavicles, and bilateral scapulae, and the fundus gas. On the lateral projection, here you can see the trachea. That's the first bronchus is the right upper lobe bronchus, and then comes the left upper lobe bronchus. The right descending pulmonary artery is anteriorly located, and the left pulmonary artery is more superiorly but posteriorly located. And the heart contours, we can see the inferior vena cava shadow can be seen, and here is the scapula bilaterally, and we can see the costodiaphragmatic sulci posteriorly, the right hemidiaphragm, the left hemidiaphragm, and gastric fundus gas. During interpretation, we can use the terms upper, middle, and lower to define the lung fields. Also, we can use central and peripheral lung terms. Cardiac size measurements based on X-rays are shown to be not very accurate. However, cardiothoracic index is the most commonly used method. It is normally between 50 to 55%. On lateral radiographs, the heart contour should not extend beyond the posteriorly beyond the line that is drawn along the anterior wall of the trachea and downward. As an example here, this patient was born normally with a cardiothoracic index of 57. The heart does not extend beyond the line that is drawn along the anterior contour of the trachea and downwards. And on the follow-up, as a newborn, the patient had an enterovirus myocarditis and developed a dilated cardiomyopathy and a cardiomegaly, and the cardiothoracic index increased to 64%, and the heart extended beyond the anterior tracheal line. And on the follow-up at 7 years, you can appreciate the cardiac enlargement, 61%, and the heart extending beyond the tracheal line. I'm gonna skip to normal variants now. Due to the growth of the body during childhood, we see a great variation on chest X-rays. Here you see the chest X-rays of the same patients at birth and at 15 years old. The upper chest is usually smaller in neonates, and the chest has a bell shape normally. The mediastinum appears larger, the heart has a more spherical shape, and the cardiothoracic index can be normal up to 65%. The aorta and pulmonary arteries are difficult to identify due to the thymic shadow. The cartilaginous portions of the ribs anteriorly are larger, as well as the costochondral junctions here. The costochondral junctions are larger as if the anterior aspects of the ribs are splayed, and because the cartilage is not seen on the X-rays, but we can see it on the CT. You can see here, these cartilaginous components are very large in children, and this gives a flexibility for the chest. The thymus is probably the most commonly encountered pathology mimicker on the chest X-rays. The thymus has a right and left lobe and located in the anterior superior mediastinum. The border of the heart and the inferior border of the thymus may blend, or there may be a notch at the junction of the border of the heart with the inferior border of the thymus. When there is air within the mediastinum, the thymus can be delineated much better, as you can see here on the X-ray and on the CT. And when the thymic lobes are elevated, it may cause a sign called angle wing sign. Sometimes thymus may produce the sail sign, as you can see here. If the patient is rotated to right, then it may be incorrectly interpreted as an upper lobe pneumonia. And here you see another normal thymus with prominent right and left lobes. When the patient is rotated to left, the outer contour of the thymus can show an undulation. It's a gentle undulation, and this is caused by the impression of the cartilaginous portions of the ribs. We don't see the cartilaginous ribs, but we can see their indentation, and this is a normal sign, and this is called thymic wavy sign. The thymus can extend down over the hilum and over the heart and obscure the hilum. Here, same patient, 8-month-old, the thymus is extending all the way down and obscuring the hilum and main vessels. On the left, also obscuring the assessment of the main vessels and the left heart contour, but same patient. After the involution of the thymus, we can see them very well. Another example of a newborn with a prominent thymus, and same patient at 7 years old. First one, we are not able to see the hyla, but on the follow-up at 7 years, we can see it very nicely. This usually starts after 3 years. There has been a time in the history that the normal thymus were considered as a pathology, as you can see in this paper published in 1950s, and they called this thymic asthma, and they treated these children with radiation treatment. So, for example, this one has a sail sign, which is actually a normal finding. Most likely the patients were presenting with upper respiratory tract symptoms at this time, and they thought this is caused by this thymus and compression on the trachea, so they decided to treat them with radiation, with high dose radiation. So after the radiation treatment, the thymus is obviously involuted, and they believe that they treated the child, and most likely the patient's symptoms usually resolve by then. We are not doing this anymore. Sometimes we just do CTs. But how to confirm a normal thymus gland? We shouldn't do any CT studies. For example, 3-month-old male, we saw this opacity anteriorly on the right upper lung. Is this a mass or not? Shall we do a CT? No, we shouldn't. We should do an ultrasound. On the ultrasound, we can clearly see a normal thymus. It is homogeneous. It has the typical gland echo texture, and there is no fat, there is no calcification, there is no mass effect, and this we can confirm with an ultrasound, and we don't need any further investigation for this patient. And also these patients are usually asymptomatic. So for example, this one, 13-year-old male with some respiratory symptoms. On the X-ray, frontal and lateral projection, but this cannot be thymus because the patient is over 3 years now, 13 years old, and there are also foci of calcification, better seen on the lateral view. And this patient actually turned out to be a germ cell tumor with typical fat and calcification content. Another example, 7-year-old girl with an enlarged mediastinum. Is this a normal thymus? No, because the patient is too old, over 3 years, and the lateral contours of the thymus is convex. We don't expect to see this at this age, and this actually turned out to be lymphoma involving the thymus. There are some normal variants that are commonly mistaken for pathology on the chest x-rays. One of them is deviation of the trachea. Here you see deviation of the trachea to right side, and here you see deviation of the trachea to left side. One of them is a normal variant, the other one is a pathology. So here you can see it better, and this one is physiologic, this one is pathologic. This usually happens in infants, especially when they are in supine position. The trachea tends to deviate to right side because of the aortic arch, which is located on the left. But when you see a leftward deviation, it's always pathologic. You should look for a mass or a lymphadenopathy or a vascular malformation. Another normal variant is superimposition of scapula. You may think that this is very simple to differentiate, but it's commonly confused with pathology. Here you can see the superimposition of the scapula with the lung, and you don't see it on the lateral because it's somewhere here. And the reason the patients raise their hands during chest x-rays is to remove the superimposition of scapula. As you can see here, the patient was not able to raise arms. That's why this is causing the superimposition. Another normal variant is here, seen in females. If you noticed, there is this opacity extending from the neck and extending to the right hilum. Little bit different at the right hilum. This is actually not a pathology. Hair braid and the hairpin at the end. This is not a hilar lymph node or a calcification. Another normal variant is the posterior aspects of the lung bases. The lungs actually extend down to this level normally, but it's superimposed with the opacity of the liver. And sometimes these opacities can be very prominent and may be misinterpreted as pneumothoraces. But this is just a normal finding, and we should be aware that the lungs are actually ending down here posteriorly, anteriorly here. Another normal variant is the breast shadow. As you can see here, this patient was sent to our hospital in the middle of the night because of pneumonia or lung crisis, but it was just the breast shadow, as you can see here. The breast shadow may be a problem in males if they have a prominent pectoralis muscle shadow. If they work out, you may encounter with this appearance, and this patient unfortunately had to have a CT study to confirm this finding, because initially thought to be bilateral pneumonia, but however you can see that the pectoralis muscles are prominent and just normal. Another normal variant is the contour of the left atrium. As you can see here, not the right atrium. Right atrium contour is here. That's the left atrium, right aspect of the left atrium. The correlation with CT is here. That's the left atrium. And that's the contour of the right atrium here. This can be seen in normal individuals, although they have a completely normal heart, and this should not be misinterpreted as a paravertebral mass or opacity. Next, I would like to talk about paravertebral opacities. In routine practice, we sometimes see paravertebral opacities. For example, this patient is presenting with cough and fever with a question of pneumonia, And the lungs are clear, but is this a normal chest X-ray? No. Look at this. The paravertebral spaces should be clear, and we see an opacity that should not be there. On the lateral, we don't really see it, but it turns out to be a neuroblastoma. And on the lateral view, it's not really possible to see it, likely due to the superimposition with the spine and the liver. There are other causes of paravertebral opacities. Just to give you examples here, neuroblastoma with calcification, left paravertebral confirmation with CT, left paravertebral opacity, ganglioneuroma in the same spectrum. And another opacity here turns out to be lymphoma as confirmed by an ultrasound study. And this one is involving a longer segment and turns out to be aortic aneurysm detected by X-ray initially. Next, I'm going to talk about pneumonia, which is the most common indication of chest X-rays in children. Some facts regarding pneumonia. The viruses are more common at all ages. Between 4 months to 5 years, 95% viral. Under 2 years, the most common etiology is respiratory syncytial virus, RSV, and the most common bacterial etiology is Streptococcus pneumonia at all ages, except the newborn period. Between 6 years and 16 years, the frequency of Streptococcus pneumonia and Mycoplasma pneumonia increases up to 30%, but still the viruses are more common. And imaging has limited value in the differentiation of viral and bacterial infections, and they commonly coexist. Viral pneumonia is more common, so let's start with the pathogenesis of viral pneumonia. We see bronchiolitis in viral pneumonia, which means small airway inflammation that is 2 mm or under. You can also call it lower airway inflammation. Basically, we see bronchial wall thickening, which means when there is inflammation, there is narrowing of the lumen, and the narrowing of the lumen will be exponentially higher when you think in the cross-sectional area. And there is inflammation in the peribronchial interstitium and perialveolar interstitium. And when there is additional mucous plugging, that will cause atelectasis. If it is completely obscuring the airway, it will cause atelectasis. If it is partially causing airway or even without mucous plugging, there is narrowing of the airway, which means that there is more air going in than air going out. So this will result in hyperinflation. So in this case, the main findings of viral pneumonia is hyperinflation, peribronchial interstitial opacities, peribronchial thickening, and also atelectasis, which could be subsegmental or segmental or lobar, and peribronchial areas and infrahilar regions are the most common for these subsegmental atelectasis, and right upper lobe atelectasis is the most common, especially associated with RSV. Here you can see an example of bronchiolitis in a 5-year-old girl with asthma. The patient presents with asthma exacerbations at different years, and she didn't have viral infection. So what we see is hyperinflation and perihilar peribronchial thickening and perihilar interstitial opacities, and some streaky opacities that may be subsegmental atelectasis. And this is moderate, more severe, and mild at this time. But when it comes to bacterial infection, the pathology is mainly within the alveoli, as opposed to interstitial in the viral pneumonia. And in bacterial pneumonia, there is consolidation. When describing in a report, we also have nodules around opacities under 3 cm, When the nodules are larger than 3 cm, we describe them as mass. And these atelectasies, which can be subsegmental, segmental, or lobar, are also radiopaque. So it is not always possible to differentiate between these opacities, and it's safer to describe them as airspace opacity in a report. And airspace opacity can be caused by atelectasis, aspiration, hemorrhage, edema, pus, or even tumor cells. Here is an example of bacterial pneumonia. This is also called round pneumonia because of the configuration. It's hiding behind the heart on the frontal projection but cannot hide on the lateral projection. This is a specific type of pneumonia which is seen usually under 8 years, because there are collateral airways between the alveoli in children under 8, and these are called pores of Kohn, canal of Lambert, and canal of Martin, and that's why the infection is easily spread in a confined area and causing round pneumonia. And over 8 years, you may need further investigation to exclude an underlying tumor. So we have the viral pneumonia with typical perihilar peribronchial inflammation, and we have the bacterial infection with typical airspace opacity or consolidation. So, and these are the patterns that I draw. So, but it's not always possible to differentiate them because there are always a combination of the infections and there are overlapping features. And the most common mistake when interpreting an X-ray is making a false diagnosis of bacterial pneumonia. And this is happening because of interpreting the atelectasis as consolidation. The patterns can be variable, and the most common ones are, as compared to a normal one, typical viral pneumonia. Viral pneumonia can be completely normal, by the way, or just some hyperaeration, or can be perihilar interstitial opacities. These can be associated with subsegmental atelectasis. Also, right upper lobe atelectasis is very common, especially with RSV infection. We can have a mixed viral and bacterial infection, and we can have consolidation associated with perihilar interstitial opacities. They can be bilateral. We can see a bronchopneumonia type. We can see just focal consolidation. Consolidation can be associated with pleural effusion. Bacterial pneumonias can be associated with pleural effusion, and this is a helpful feature. Viral infections usually do not, and atelectases do not. So that is important for the differentiation. You can have bilateral pneumonia, and sometimes we see an advanced bacterial pneumonia causing a white-out lung, and this may be associated with pleural effusion as well. So how reliable is the radiographic pattern? Because this is the most common indication in the ER. So let me give you examples of a bacterial infection with airspace opacity, viral infection, bacterial infection, viral infection, viral infection, and bacterial infection. So the positive predictive value, which means to exclude bacterial pneumonia, the number is 30%, which means 70% of children diagnosed as bacterial pneumonia actually have viral pneumonia. But negative predictive value is very high, which is the area who do not need antibiotics, because in viral infection we don't use antibiotics, in bacterial infection we use antibiotics. This is basically how we can affect the management of these patients by using X-rays. So this means that 8% of the children diagnosed as viral pneumonia actually have bacterial pneumonia. So it is never 100%, and clinical and laboratory findings should also be considered when making a diagnosis of viral or bacterial infection. There are specific types of infections, for example, aspiration pneumonia. It's basically the radiographic pattern is same. We see airspace opacity, but the distribution may be helpful because it's usually central lungs in a lying patient involving the dependent parts of the lungs, as in this case, confirmed with CT. So you can suggest a diagnosis of aspiration pneumonia based on the distribution. And there is also an important point that bacterial pneumonia can be associated with parapneumonic effusion or empyema. Empyema needs drainage. Parapneumonic effusion does not. So how do we differentiate based on the X-ray? It's not always possible to differentiate based on the X-ray, and even if we differentiate, we don't know if it is amenable to drainage. For this purpose, we can use ultrasound, CT, or MRI. And for example, here we see a complex collection. This is most likely an empyema, but a lot of septations, and it's very complex, so may not be amenable to drainage. This one is a pleural effusion and pleural effusion, as you can see. When the infection is extensive, it may involve an entire lung, and this is called whiteout hemithorax, whiteout lung. And whiteout lung can be caused by also other pathologies such as a tumor or atelectasis or other pathologies. So how do we differentiate on the X-ray? On the X-ray, the position of the trachea is very important to differentiate. We look at the trachea or mediastinum. If the trachea is unchanged, and this is usually seen in bacterial pneumonia or consolidation because the alveoli are filled and they do not change the position, they don't exert mass effect. And also when there's small pleural effusion, they don't cause mass effect and displace the trachea. Also, chest wall masses or pleural masses will not change the position of the trachea. But when it is pushed to the other side, this can be caused by pulmonary masses, tumors, and large pleural effusion. If it's large enough, it can push. When the trachea is pulled to the same side of the white lung, this can be secondary to total lung collapse, congenital pulmonary agenesis, or when the patients have pneumonectomy, we can see this. After pneumonia, I will skip to pneumothorax. This is a commonly encountered pathology in emergencies and NICU units. And here is a 15-year-old with asthma. We don't see the lung parenchyma on the left side. This opacity is representing the collapsed left lung. And this patient didn't have significant symptoms and did not have tension pneumothorax, which is very important. When there's mass effect, as you can see here, significant displacement of the heart and mediastinum along with trachea, and this patient needed immediate intervention. Here is an example of pneumothorax in a 16-year-old male. The chest X-ray was interpreted as normal, but this patient actually had a tiny pneumothorax along the apex of the left lung. These areas are very challenging due to the superimposition with the bones and clavicles and ribs. So it was missed, and the patient presented with an enlarged pneumothorax on the left side with complete collapse of the left lung. So when there is pneumothorax, we should also pay attention to the underlying cause. For example, in this patient on the X-ray, we see a tiny pneumothorax, but there are also these well-circumscribed bulla at the apex of the lung, and this is confirmed with a CT study. So most likely these bulla are the cause of pneumothorax, and they rupture and cause spontaneous pneumothorax. Pneumothorax is also common in NICUs. Here is a newborn with surfactant deficiency disease and a large pneumothorax on the right side, and a tube was already inserted. Here on the left side, when it's like this, when it's large, it's easy to detect, but they can be very small and subtle. For example, in this case, it's not clearly seen on the frontal projection. It's just some lucency along the contours of the heart and along the costodiaphragmatic sulci. But when the lateral view is obtained, or cross-table view, the air can be seen better within the non-dependent aspect of the chest, and this is confirming the presence of pneumothorax. After pneumonia, I would like to continue with foreign body ingestion and aspiration. This is very common because children explore the world with their mouth. They aspirate anything. So, 3 different examples of metallic foreign body ingestion: 4-year-old with coin, 9-month-old with magnet ingestion, and 11-month-old with bottom battery ingestion. And the appearance is typical. On the frontal projection, we see the coin end phase, and on the lateral projection as a discoid shape posterior to the trachea. We should make sure that it's not in the trachea, it's not in the airway, and it's in the esophagus. And it, as you can see, even if you don't have a lateral view, you can see that it is the size of the coin is larger than the trachea, so it cannot be within the trachea. Bottom battery ingestion is extremely dangerous compared to others because they can cause perforation in the esophagus even within half an hour. So they need to be urgently removed. The bottom battery appears something like this. As you can see, they can be in different shapes, and even if they are dead, they can still cause damage. And I would like to share an experiment of Dr. Mary Zakos with the hot dog. In this one, she is placing a bottom battery and just observing the bottom battery damage in the hot dog, starting even within hours and becoming worse at 20th hour. So these are extremely dangerous ingestion types. Foreign body aspiration can also be very dangerous. As you can see here, there is a nail within the right lower lobe bronchus. This is somewhat the most common location for foreign body aspiration due to its position and angle. And if you're lucky, you are able to see the foreign body directly on the X-ray. This happens usually when there is bone or tooth or a metallic foreign body like this, but most of the time we don't see it. So for example, here there is a tooth, molar tooth aspiration, and because the airway is partially obscured, it is causing atelectasis. So we can see the atelectasis distal to the airway. In this one, foreign body aspiration, a peanut aspiration to the left main bronchus, we are not able to see it directly, and this is the most common scenario. But what we are seeing is hyperinflation on the same side, and this is not technical. And after endoscopic removal of the foreign body, we can see normalization of the lung volumes. Another example of foreign body aspiration is sunflower seed aspiration to the right main bronchus, as you can see here, and these are after removal. As you can see, there is air trapping, and on the right side, hyperinflation. There is also associated atelectasis. It's not lobar, it's segmental or subsegmental. Looks like there is no complete obstruction of the airway, and we are not able to see the sunflower seeds on the X-ray. This is another example of a 2-year-old with plastic toy aspiration to the left side, because it looks like the airway is completely obstructed and caused complete collapse of the left lung. and there's the cutoff of the airway, we can even see that. And after endoscopy, there is improvement, gradual improvement of the aeration of the left lung, immediate improvement. For the diagnosis of foreign body aspiration, inspiratory and expiratory views as well as decubitus views can be helpful, because when there is obstructed airway, we can see it better on the expiratory views because of the airway trapping. The normal lung will be deflated, but on the expiratory view, the pathologic side will not show deflation. Same idea on the decubitus views. The dependent lung remains inflated when there is airway obstruction, and the dependent lung remains deflated when it's normal. So here is an example of a foreign body aspiration in the right main bronchus. There's air trapping on the right side, and because we were not sure, we used the decubitus views, and the patient is now right decubitus, and we don't see deflation of the right lung with what we normally expect. The left lung shows deflation, right lung does not, because there is air trapping on the right side, and there is foreign body aspiration on the right side. The final topic is trauma. Trauma in children is somewhat different than adults because of flexibility of the chest. Because of the high cartilaginous component, the chest is very flexible, so we don't usually see fractures, even with major trauma. For example, this patient had a major trauma, motor vehicle crash, and lung contusion, but there was no rib fracture, which is very unusual in adult patients. And there is a specific type of trauma that we should never miss. It is non-accidental injury, because fractures are not common in children, and especially rib fractures we don't expect. When there is a fracture in a child, in an infant, we should always consider non-accidental injury. During the acute phase, it may not be possible to diagnose, but you can see it as a linear fracture without a callus formation. But usually it is easier to see the callus formation and make the diagnosis of fracture. When there are healing fractures, especially in the posterior or lateral ribs, they are very suggestive of non-accidental injury. I would like to share the Canadian Pediatric Society practice point regarding the non-accidental injury. As you can see here, rib fractures are considered a red flag for non-accidental injury, and that's why whenever we see a rib fracture, we should alert the pediatrician for non-accidental injury. Overall, 25 to 56% of all fractures in children are due to inflicted trauma or non-accidental injury or child abuse. So finally, take-home points. Chest X-rays are among the most challenging imaging studies. A broad knowledge regarding the normal variants and pathologies in children is required. Thymus can show extreme variations on chest X-ray in infants. Always check paravertebral regions for incidental lesions. One of the most common mistakes when interpreting an X-ray for pneumonia is making a false diagnosis of bacterial pneumonia. Esophageal battery ingestion requires urgent removal to avoid perforation. Air trapping, as best demonstrated on expiratory and decubitus views, should alert for foreign body aspiration in infants. Position of the trachea is helpful in the differential diagnosis of unilateral whiteout lung. Pay attention to small apical pneumothoraces in adolescents and neonatal pneumothorax that is better demonstrated on cross-lateral views. Unexplained rib fractures are considered as a red flag for inflicted injury or child abuse. Thank you for watching.